some of these patients come in and they're obviously not in good condition. And then we know right away that that's not a patient we're going to take to the operating room. The cancer extends through the belly cavity, and it takes a toll on people. Their intestinal function starts to decline. They can't eat. They get peripheral wasting, malnutrition. Their albumins drop. They come in dehydrated. Sometimes they have a deep vein thrombosis or even a pulmonary embolism. A variety of things happen to them as a result of this advanced disease, and they've deteriorated to the point where we say, now this patient isn't ready for the operating room, or they just have a lot of medical problems anyway. But the patient who's deteriorated, that's one patient we say, let's calm this disease down with chemotherapy first. Then there are other groups of patients that we select by doing CA-125 and CAT scan and exam, biopsy, a full evaluation, and sometimes laparoscopy. And if everything tells us that this patient is somebody who's fit for surgery, and if we go in there, the CAT scan looks like pretty localized disease, we're gonna do a reasonable job at getting all of it out without doing too many big things, then we're going to select that patient to have upfront surgery. If, on the other hand, the CAT scan shows, for example, extensive liver metastases, we know that we're not going to accomplish what we need to surgically, and we'll give chemotherapy first. In some patients, we know that's all we're going to do is chemotherapy. But there's a large group of patients that are in between where the CAT scan doesn't look too good. There's widespread tumor in the belly cavity, including in the upper abdomen, big lymph nodes high up along the aorta or in the portal system, a lot of disease along the diaphragm, around the liver, disease in the root of the mesentery, diffuse carcinomatosis. We're a big volume ascites. We can be pretty confident that we're going to go in that belly and not do a real good operation, not get that patient down to real small volume disease. And so those patients, we're going to give chemotherapy first, 3 cycles, and then reevaluate. If they respond or at least have stable disease, then we'll do the surgery.